Thank you, Jim, and thank you for coming, all of you, so early in the morning to this session. My name is Mike Pringle. I'm a former general practitioner. I worked in general practice for over 30 years, and I was Professor of General Practice at the University of Nottingham, and I've been President of the Royal College of General Practitioners for the last 18 months. It's a real pleasure to be here, and I'm here with two real experts in the field, Jonathan Botting, who is a general practitioner and a GP surgeon, and Imran Rafi, who heads up our clinical unit in the college. And I'm going to by most of my comments are by way of introduction to their talks. We hope to leave time for questions at the end. We will leave time for questions at the end, and that's the most important part, I think, of this session. I want to start by just giving you a little bit of context to where general practice is and the challenges and issues that general practice faces at the moment. Now, you will have noticed, those of you who work as, in secondary care, that there is a real challenge of the ageing of the population. And over the next 20 years, we're going to see a doubling of the old proportion of the population. It does mean that in terms of unscheduled care and hospital admissions, that the old model in which the hospitals were seen as a repository of acute and care on people who were in the early years of their lives who required dramatic surgery or intervention or medical care in order to have them back into the community in the state that they arrived in, that era is coming to an end. And hospitals, as you know, are now becoming predominantly repositories for people who have comorbidity and who are elderly. This means the model of the interface between primary and secondary care is changing quite dramatically and will go on changing as time goes by. Now, in general practice, the influence of this is quite profound. We see the average patient for 5.5 consultations per year, and the average consultation lasts just under 12 minutes. Well, when you look at the elderly, however, we see the elderly more than once per month. We see them 14 times a year. So that means that, and they have the longer consultations. So when we talk about a doubling of the number of elderly in the population, the implications for general practitioner and general practice team workload are really quite profound. And it's not just the raising number of the elderly, it's the raising number of elderly with long-term conditions, and especially with comorbidity. And that is going to really increase quite dramatically as longevity kicks in and people manage with major chronic diseases for so much longer. Now, as you know, 9 out of every 10 contacts with the NHS occur in primary care. There are over 1 million consultations in primary care every day. There are 1.5 million prescriptions issued in primary care every day. The workload in primary care is quite phenomenal. In the last 10 years, we have seen a 2% rise in the whole-time equivalent number of general practitioners, and yet we've seen a much larger rise in the population during that time. We've seen an increase in the consultation rate from 4 to 5.5 on average, and I've told you about the increase in the elderly. And we have now, as I say, a 12-minute consultation pattern throughout the UK on average, and over 90% of our patients think that's too short. So we are in a situation in which there is no rise in the number of general practitioners, there is a rising consultation rate, and there is an expectation of longer consultations, and that I'm sure is something you're experiencing in your outpatient clinics too. Now, alongside this, we have a 30% reduction in the last 10 years in the number of community nurses working alongside us, and we've had a 7% reduction since the peak 7 years ago in the number of practice nurses. So we do have what is building up to be quite a profound workload problem and workforce problem in primary care. One of the things that I've been very sad about to see in my working life is the exacerbation of the inverse care law. I'm sure you're all aware of the inverse care law, which says that more care is delivered to those who need it least. And when I was a medical student and a young doctor, I believed that that was an artifact of the past and that one of the sacred duties of the NHS was to reduce the inverse care delivery of care throughout the UK. I think until 10 years ago, till 2004, and we can time it actually to the new contract for general practitioners in 2004, the inverse care law was being addressed. there was provision in the poorest areas of Britain. There were strong incentives for practices to operate there, and the distribution of doctors was reasonably equal throughout the UK. If you now look at the pattern and you look at the top decile for deprivation of wards in Britain, and you look at the lowest decile, in other words, the most affluent areas of Britain, and you compare the top 10th, the decile, to the lowest decile, then you will find there are twice as many general practitioners in the affluent areas as in the deprived. That is a new phenomenon over the last decade, and it's getting worse. And you may have seen on the front page of the Times yesterday the fact that there is, in the NHS, a thing called MPIG, a rather inelegant name, for a minimum income guarantee for the practices that operate in the poorest areas of Britain, and that is being withdrawn by April next year. If that goes ahead, then actually quite a few practices will just lock up their doors and stop operating in the poorest areas of Britain. We are therefore facing quite a profound inequalities agenda. Now, why does that matter? Well, if you look at the people who live in the poorest boroughs and the poorest areas, they have a much worse life expectancy than those of us who live in nice leafy suburbs or country villages, and they get their comorbidity, their multimorbidity, 12 years earlier than the average population. So we're talking about people who die young, but not only that, but have more illness earlier, and they live with that illness for longer than in the more affluent areas. This not only puts, is I think a shame, it's a stain on a civilized society like ours, but it also puts an incredible strain on the National Health Service. So it's a major issue for all of us. Much more relevant to you and I guess, in this session, is the fact that what we've seen in the last 10 years or so, maybe 20, is an increasing fragmentation of care. Now, I'm going to come back to the issue of generalism in a moment, but part of the fragmentation of care is because the ologies have proliferated, and there are more and more people who do a very restricted bit of clinical practice. Now, that is actually to most of our advantage. To have people who are very good at certain very well-defined areas of clinical practice does deliver better care for the people who need it. But actually, a lot of our patients now have comorbidity, have very vague, diffuse morbidity, and for them, the idea of someone who only does one very exact part of their body is not what they require. And that is causing quite a lot of problems. So if I characterize it, that I have some patients who have become professional patients. They actually wake up every morning and wonder where it is they've got to be today, somewhere in the NHS. And they will go to a hospital for one outpatient clinic, and the next day they may be in another outpatient clinic. They will come to our surgeries for a blood test and come back again a few days later to see a nurse or a GP, and then they'll come back again a few days later to see the pharmacist or someone else. They will be travelling through the NHS on a daily basis, causing, I have to say, enormous cost to the NHS and enormous expense to them personally in terms of their commitment they have to make to their healthcare and also their underlying costs of travel and everything else. And I have to say, as someone who watches the NHS on behalf of my patients from the outside, the NHS looks as if it's exquisitely well designed for the people who work in it and not for the people who use it. And that has to be something that we address over the next decade if we're going to continue to have the trust and the confidence of the people of this country. So the diffuse fragmentation of care, the lack of individual responsibility by clinicians for the patient rather than for the organ or the disease, is actually something that is causing quite a lot of concern among general practitioners as a community. And the last challenge is one you're very familiar with, which is the financial challenge. We can't make that go away, and we're going to have to live under the constraints we have. You know very well that when they talk about maintaining the NHS budget, that is about the same sum in real terms coming into the NHS every year. Well, I'm not sure what NHS healthcare inflation is at the moment, but the last figure I have is for 3 years ago when it was running at 11%. That's because our drugs get more expensive, our equipment gets more expensive, our whole infrastructure becomes more expensive than the average rate of inflation. When you have a standstill budget and you have 11% healthcare inflation, you therefore have a real terms drop of 11% in the money you can spend year on year. And that is being felt throughout the service. And I have to say it is being particularly felt in general practice and community, where our percentage of the NHS pot has dropped from 11% to 8.4% in the last 5 years. And if any of you know general practitioners and are talking general practitioners, you will find once you get their confidence and you get them to, after a glass of wine, to talk about what their life is like at the moment, the one common factor will be that their incomes have dropped quite dramatically over the last few years, and their practice economics have become much more stressful and difficult. So we are going through a really difficult time. So when you see the newspaper headlines of GPs wanting a bigger share of the resource, more money being put into community, it's not actually that we really want to take it from you, which we do. It is because we really want to make sure that general practice survives and community care survives, because I'm going to explain to you in a minute why that is in the interest of the future of your service and of the NHS. So what are the positives? Well, there are many generalists operating in secondary care. The people who look after the elder care physicians are one very clear example. Psychiatrists are often another. And general surgeons, general physicians. So we do have a lot of generalists in all sectors. So what I'm going to say about generalism is not just about general practice, but general practice obviously is a very generalist area of our health service. We, for years, have advocated generalism as a way of managing patients as people rather than as diseases, and trying to make sure that we short-circuit a lot of the care that might be deemed necessary by very specialists, as we call them, partialists, who might want to do very detailed investigations on various things, whereas the patient as a whole, it may not be necessary. Now, I'm told by my patients, although I'm not a witness to it myself, that when an elderly person gets admitted, if they have diabetes, they always get referred to a diabetologist. If they have an eye condition, they get referred to an ophthalmologist. They get a whole load of people come to see them, or they get sent up to outpatients. And one of the jobs we do as general practitioners is to try and extract patients from those systems. Because often what they're referred for is just because the person who's doing the referral doesn't know, isn't confident in that particular disease area, and they spend a lot of time going from one doctor to another, quite unnecessary for things that we believe in general practice are perfectly well controlled, given the totality of that patient's care and the priority order of the problems they face. So one of the things we're hoping for is a resurgence in all sectors of the health service of generalists who can see the patients as a whole and who can then consult with specialists where necessary rather than as a rule. Now that means that we've got to see a change in training. And when you look at shape of training, that has signalled very clearly a change in the nature of generalism in the health service and a re-emphasising of generalism as the core rather than the add-on to the way in which patients are looked after. If you look at the Royal College of Physicians, and I emphasise it didn't come from our college, the Royal College of Physicians paper on the future of hospitals, the Future Hospital Commission report, that accepts that generalism has got to be at the core of the delivery of services within a secondary care setting. So I believe that the tide has turned as far as generalism, and I hope that all young doctors will now see themselves first and foremost as generalists, and then as partialists. And I do hope that we will see in the future a revaluation of generalism so that especially in the secondary care setting, general physicians, surgeons, psychiatrists or whoever are valued as highly or more highly than their more detailed and specialist colleagues. So that is a positive light on the horizon and something you may want to pick up with us. The second thing I want to just highlight is that many general practitioners do an area of specialism within their generalist work, and that's very much something we want to encourage. We don't want to lose their generalism, but we're very happy for people to develop areas of interest which they're skilled, properly trained, properly overseen, properly audited, and properly quality assured. So that means that we have got, within general practice, a really skilled and important set of colleagues who do surgery within general practice. And Jonathan Botting, in a moment, will be explaining that area to you and his experience in it. And then the last real positive we got at the moment is commissioning. It's very difficult to ask the CCGs to be effective in an environment in which they have reduced funds year on year. But all of them are aware of the need to try and smooth the patient's journey through the healthcare system and to try and make sure the pathways of care are as effective and patient-centric as possible. Now that means they are looking at referrals, they're looking at how the patient experience and trying to design new ways of helping patients through the system. I think that's really positive because I think that we need that sort of rethinking at the moment. We must get the best value, we must get the best patient safety, and we must get the best outcomes from the health service. And that means that we must be looking at how services are commissioned. And Imran Rafi will be talking about that in a moment.